Hello, my name is Charlene Hagerman, and I'm going to be doing a short presentation on Cachexia syndrome. So I'm going to go through a few definitions. So cachexia is an involuntary weight loss of more than 10% of premorbid weight. Anorexia is appetite loss, and anesthesia is an abnormal physical weakness or lack of energy and mental fatigue. So what is Cachexia syndrome? It's a medical term to describe weight loss and muscle wasting that occurs when the body is unable to process nutrients from foods. It's very different from general weight loss, and it is often accompanied by anorexia, but not always, and asthenia. So what happens in cachexia? It's a complex process that involves several organs and systems in the body. It's mostly due to the alterations in protein, lipid, and carbohydrate metabolism, and the accelerated breakdown or catabolism of these compounds. Catabolism is caused by the release of inflammatory cytokines, which are a group of proteins that act as chemical messengers by the disease, such as cancer, and the immune system's response to chronic illness. These chemicals speed up metabolism so that calories are used up faster than they are consumed. Cytokines also suppress appetite and cause severe fatigue. Weight loss proceeds rapidly with the accompanying protein and lipid breakdown, even with adequate caloric intake. It's not the same as starvation, where in starvation the metabolism slows in response to decreased nutritional intake. So the prevalence. In the cancer setting, there is a higher rate with solid tumors as compared to the hematological or blood malignancies. The exception to this is breast cancer. There's an increased prevalence if one has advanced lung cancers and GI malignancies, such as malignancies in the pancreas, stomach, and esophagus. It can occur with chronic diseases as well, such as end-stage lung disease, end-stage heart disease, end-stage kidney disease, and HIV and AIDS. Up to 80% of people with advanced cancer may develop some degree of cachexia. Cachexia syndrome can also be made worse from the side effects of some treatments for cancers, and it is the most common cause of weight loss in palliative patients. The incidence of cachexia, 80%, up to 80% with advanced cancer can develop this. 16 to 40%, 42% of people with advanced heart disease can also develop cachexia, and up to 30% of people with the end-stage COPD develop it, and 60% of people with chronic kidney disease in the later stages can develop cachexia. So what are the results of this? Rapid weight loss. Often there's appetite suppression, severe fatigue, loss of muscle and fat mass, anemia, which is low blood cell count, red blood cell count, and often there's associated nausea and almost always considerable stress for patient and family. How can we control cachexia syndrome? Unfortunately, once one has, it's often considered irreversible and does not usually respond to treatments. Artificial nutrition is not usually effective and usually does not improve quality of life. If cachexia syndrome is anticipated and there is early maximizing of nutritional interventions and exercise, the onset may be delayed. Comprehensive assessment should be done to rule out any potential reversible causes of anorexia and weight loss. So how do we assess cachexia syndrome? As we do with other symptoms in palliative care, when we're doing a comprehensive pain assessment or a comprehensive assessment of shortness of breath, we use the acronym OPQRSTUV. So with cachectic syndrome, we ask about the onset. When did the weight loss start to occur? Or when did the lack of appetite start to occur? What with the P provoking, what brings on the anorexia? What makes it better? What makes it worse? And for the quality, describe how it feels. How much weight loss is happening over what length of time? For the severity, ask about ask the patient to rate their appetite on the scale of 0 to 10, with 10 being the worst possible appetite. Is this rating consistent? Is there other symptoms accompanying this, such as nausea, perhaps pain, shortness of breath could be contributing? And the treatment, is the patient on any medications? Are these medications effective? Are they having side effects from the medications? And what is the person's understanding? How has this condition affected the patient or yourself and the family? What is your understanding of what is happening? And value. So what is the goal of this symptom? How does it impact the quality of life? How does it impact the family? So a completion of a full physical exam is also important, including the serum levels of the cytokines. Assess for swallowing difficulties. Assess the oral hygiene. Is there any evidence of infection of thrush? Is there anything that could be causing pressure on the stomach, such as a tumor or fluid that may be impacting appetite and the ability to eat and drink? Is there any malabsorption syndromes? So we need to exclude any possible reasons for weight loss and anorexia as well that could perhaps be treatable if the patient wants. So management, we need to explore with the patient and family their understanding, their fears, and their expectations with regards to the weight loss. Counseling is important, especially as it frequently impacts one's self-concept of their body image. Very valuable members of the team that should be involved are dietitians and social workers, and it's very important to discuss and explore the patient and family's goals of care. So in conclusion, we need to explore the psychological impact of this weight loss with the patient and families and provide education regarding requests for artificial feeding. We need to focus on eating for pleasure rather than focusing on the nutritional value of food at this time. There needs to be treatment for nausea if that's present. Encouraging small, more frequent meals might be helpful, and excellent mouth care is very important. Appetite stimulants may be considered at this time, but only if the patient still enjoys eating. There's no sense giving appetite stimulants if the patient doesn't have an appetite. And the weight loss continues. And knowing that the appetite stimulants or the increase in calories won't necessarily improve and probably will not improve their weight and life expectancy. And family studies have demonstrated that having Cachexia syndrome ranks highly for physical causes of suffering and contributes greatly to both the patient and family psychosocial distress. So it's very important to get the supports for the patient and family at this time and ensure that education is provided regarding Cachexia syndrome, what it is, and how best to cope with it. And just to conclude, here's a list of the references that I used to compile this presentation. Thank you.